Good afternoon, everybody. I'll make it quite simplified and try to be on time because this Dr. Chang has covered most of this hemodynamics other part. So today I'm going to deal with this parturient with congenital heart disease and this perioperative management. Congenital heart disease is becoming most common source of this cardiac problem seen in this nowadays in the pregnant patient. And once upon a time, it was they're forced to be not advised for this pregnancy. But nowadays, with the advent of increasing this care in this medical science, development in medical science, now they're reaching up to the age of this childbearing age and this having the uneventful deliveries also. This relative frequencies of these lesions, and so we find this in the congenital heart disease, there is most commonly presentation is a ventricular septal defect and the arterial septal defect and this patent ductal arteriosus. Divided in this as per their shunt or the cyanosis and without cyanosis. So the most common in the cyanotics is tetralogy of the phallus and tricuspid atresia. And one more, this classification is some mechanical obstruction of this trachea. This most common complication is happen with this cardiac disease with parturient. There is a miscarriage. A therapy favorable to this mother can be associated with the impairment of the child. In extreme cases, as treatment measure which protect the survival of this mother can cause the death of the fetus. Cardiac surgery is indicated when this medical therapy or the interventional procedure fail and mother life is threatened. Maternal mortality during this cardiopulmonary bypass is now similar to that of this non-pregnant patient, non-pregnant woman, but there is significant morbidity, this including the late neurological impairment that is 3 to 6% in the children, and this fetal mortalities always remain high. And the best period of surgery is you can do from after passing the first trimester up to the 28 weeks. I may revise some basics before going to this exactly the individual disease. So grading of this functional capacity of the heart is very familiar with this NYHA classification. Everybody knows. Then there's come to the mortality associated with this various cardiac lesions. So it's already covered by this Dr. Chang. I'm not going to detail. This is three groups in this low risk and intermediate risk, and this high risk. Prognosis is depend on this NYHA classification. If it is 1 or 2, fall in the 1 or 2 NYHA, its mortality it is less than 1% and survival is good. If it is in this NYHA 3 and 4, there the mortality is 5 to 15%. I just skip this all. There's one more. I find this is a WHO classification for regarding the maternal cardiovascular risk. They given the grade from 1 to 4. I'm not going in detail. It's freely available in this literature, but excuse. This is WHO grade 3. There is a mechanical valve and systemic right ventricle, Fontan circulation, and this other complex congenital heart disease where this aortic dilatation is 40 to 45 millimeter in Marfan syndrome and aortic dilatation is 45 to 50 millimeter in aortic disease associated with the bicuspid active valve. And it's number 4, grade 4 WHO is where this pregnancy is really contraindicated. It's more important where this pulmonary arterial hypertension of any cause or severe systemic ventricular dysfunction where this left ventricular ejection fraction is less than 30%, or if it is for the new NYHA classification 3 or 4, previous peripartum cardiomyopathy with a special residual impairment of left ventricular function, severe mitral stenosis, or severe symptomatic aortic stenosis. So Marfan syndrome with aorta dilated more than 45 millimeter, and aortic dilatation more than 50 millimeter. So these are the class where this pregnancy is especially contraindicated, and we have to advise not to go for the pregnancy before getting the correction. Normally, this is increase the cardiac output in this pregnancy by 30 to 50%, and this is by increasing the stroke volume, heart rate, and decreasing the peripheral resistance. Physiological changes happen in this patient with the cardiac disease. There is an increase in 50% blood volume, 40% increase in the cardiac output, 25% increase in the heart rate. Approximately is going to be 80, 100, or with our patient with this anemia associated is going to the 120 and plus. There is a reduced systemic vascular resistance and increase the pulmonary vascular resistance is possible with this stenotic and this congenital heart disease. Labor and delivery itself has imposed this approximately 50% increase in the cardiac output and its oxygen demand. This decrease in this peripheral resistance is about 20 to 30% at this 21 to 24 week and return to normal at the term. I will go in this is a detail. What has happened is during this labor, there's first stage, there is a cardiac output increased by 15% because of the uterine contraction. And the second stage is increase in abdominal pressure, Valsalva caused the decrease in the venous return and this cardiac output. And third stage, there is a loss around 250 to 300 ml, and this may lead to this decrease in the blood volume and decrease the cardiac output. There are some clinical features may be correlated present in the normal in the pregnancy and this mimic this cardiac disease, like the dyspnea. It's due to hyperventilation, elevated diaphragm, this pedal edema, cardiac impulse, and this jugular raise pressure, systolic ejection fraction, that's an important one. So, and then it's present along with the left external border, occur in 96% of this pregnant women, and are believed to be caused by the increased flow across the aortic and pulmonary walls. Main predictors of this cardiac event during this pregnancy, this is the prior cardiac event, heart failure, transient ischemic attack, stroke, or dysarrhythmias. Baseline NYHA classification more than 2, or the presence of cyanosis, left heart obstruction, mitral area less than 2 centimeter, or aortic valve less than 1.5 centimeter, left ventricular outflow tract gradient less than 30 millimeter in the echo, and reduced left ventricular function, ejection fraction is less than 40%. There is criteria to diagnose this cardiac disease during the pregnancy. This presence of diastolic murmur is a feature. Systolic murmur is normally present, but this intensity, if it is grade 3, we can think of this cardiac disease is present. Unequivocal enlargement of this heart in an X-ray, presence of severe arrhythmia, atrial fibrillation, and flutter. So, what will the indication for the termination of the pregnancy with in this patient with this congenital heart disease? This patient have the Eisenmenger syndrome, that's uncontrolled Marfan syndrome with aortic involvement, pulmonary hypertension, and coarctation of aorta with valvular involvement. And this termination will have to be done before the 12th week of this pregnancy. Then it's talk about this anticoagulants, warfarin. It's you can use up to first trimester, or you can switch on this heparin or the low molecular weight heparin. But there is a definitely risk for this warfarin. If you go, there is a embryopathy is there, and embryo might have this nasal cartilage hyperplasia. Its frequency from this 15 to 25%. Stippling of this bone, it can be IUGR and this brachydactyly. This patient got to the heart failure, cardiac failure during this with this association with this infection, anemia, obesity, or it's hypertension, hyperthyroidism, and multiple pregnancy. So there is advisable prophylaxis for the subacute bacterial endocarditis while you're going for this obstetrical or this gynecological procedure. Patient on this patient with this congenital heart disease, you can give this 2 gram ampicillin IV plus 1.5 grams gentamicin IV prior to the procedure, followed by the smaller dose of ampicillin 8 hours later. You can use the vancomycin or this current bigger antibiotic, imipenem, vancomycin, that you can use nowadays. What about the contraceptive about this patient? So, oral contraceptive is not advisable in this patient with the risk of the thromboembolism. ICDs, there is a chance of infection. Progestin only pills can give, or the long injectable progestin must be better. But the best thing is the sterilization is best. If you can, the patient cannot tolerate this pregnancy, you can go for the sterilization. Just come to the anesthesia or the perioperative management. We have to, what we can keep in the mind while we're managing these of the patient, there's a choice. It's depend on the lesion, depend on the where this patient is delivering, and what the facility is available. Patient can go for the regional or the general anesthesia. That's very important thing is we have to prevent the accidental intravenous infusion of this air bubble over the IV lines. Epidural anesthesia is better in this position. If you giving the epidural, you have to be for loss of resistance technique, you have to water in place of this air. A slow onset of epidural or this graded epidural is good. This single shot spinal anesthesia we have to avoid. It can be result in the reversal of the shunt and this maternal hypoxemia increase. Supplemental oxygen you have to give all the time procedure if this regional anesthesia is planned. We always monitoring this pulse oximeter nowadays. Hypercarbia and acidosis should be avoided. And some patients who have already have the correction of their lesion, there's no need to worry. You can they usually tolerate the surgery well, and there's only antibiotic prophylaxis can be recommended this patient. And this revision of this one is air bubble and slow onset by epidural analgesia, supplemental oxygen, and this hypercarbia and acidosis should be avoided. This European Society of Cardiology has given one guideline for this managing the patient with this cardiovascular disease, and there's a recommendation. I'm not going to detail. It's freely available. You can go. It's just published in this August, and for congenital heart disease also there is a recommendation. The most commonly encountered in the day-to-day practice with getting this ventricular septal defect and the ASD and the patent ductal aortic. Usually these patients is well tolerated, and there is a risk of this left ventricular failure increase during this pregnancy due to increase in this cardiovascular volume, and but usually they are this well tolerated, and sometimes they have the supraventricular dysarrhythmias. But patients who have the successful surgery of the ASD, VSD, they can bear this pregnancy nicely, and they will come out. There's no problem with them. But patients who have this uncorrected lesion, they have the maybe challenging and complex, and but they also often well tolerate the pregnancy. But anesthesiologist must involve in this from the beginning of this. Even patient planning for this vaginal delivery, not the first cesarean, but this involvement of this anesthesiologist is better for these kind of the patient. Tetralogy of I'm going to just individual some one or two only, if time is allowed.
5 minutes.
So tetralogy of Fallot says a ventricular septal defect, right ventricular hypertrophy, right ventricular outflow obstruction, and overriding of the aorta. It's a lesion. So anesthetic consideration with this tetralogy of Fallot is to reduce the right to left shunt by this, because of this decrease in the systemic vascular resistance, decrease in this venous return, and myocardial depression. So in patient who have the successful surgery in infancy or the childhood, no special treatment is required, but antibiotic prophylaxis is recommended. But this patient who have the uncorrected lesion, this choice of induction anesthesia. Induction is general anesthesia, and narcotic induction with etomidate is advisable. Neonatal depression is can be covered with this endotracheal intubation, and this invasive monitoring is indicated here. You can go for this arterial line or this CUP line, but this pulmonary artery catheter is contraindicated with the risk of this infection, this rupture of PA artery, or this thromboembolic phenomena. Single shot spinal anesthesia should be avoided in this patient, and the slow induction of this epidural anesthesia is advisable with this caution. Next is Eisenmenger syndrome. This is another very complicated condition in this. If you present with this pregnant patient, usually this is contraindicated for the pregnancy. But if patient is pregnancy exceed, you can reach up to, you can manage this. Basically, this was initially left to right shunt. Over the time, it's become right to left shunt. And this present with the dyspnea, clubbing of nails, polycythemia, peripheral edema, and cyanosis. And an established case of the Eisenmenger syndrome, surgical correction of the defect is unhelpful and maybe increase the mortality. So, anesthetic consideration to avoid any decrease in the systemic vascular resistance. Insufficient right ventricular pressure required to perfuse the hypertensive pulmonary arterial bed and may result in the sudden death of the patient. We have to prevent this atrial arrhythmia and are particularly dangerous as the participant have the little or no cardiac reserve and need to be normal sinus rhythm to keep with this increased workload. Ampicillin and gentamicin should be given as a prophylaxis of the antibiotic. Oxygen should be administered to the all patient undergoing the surgery under this regional anesthesia, or this cesarean section can be planned. Vaginal delivery definitely is better, but the cesarean section is planned, so also conducted under general anesthesia. But they have the disadvantage, the effect of this IPP on the venous return, ventilation perfusion mismatch, high pulmonary artery pressure, increased shunt through this anatomic defect, and myocardial depression by halogenated agent. Monitoring again involves this as arterial line and CVP, and PA is contraindicated. Blood loss should be promptly reflected, maintain this vascular volume. And titrated epidural anesthesia is probably the preferred regional technique. A dilute solution of the phenylephrine may be given if needed to maintain the maternal systemic vascular resistance. So, what current status of the patient with the cardiac disease become now is safer with the improvement of treatment and management. And it was the past where this advisable not to go for pregnancy with this congenital heart disease. But now with the vast improvement in this cardiac care, advances in the reproductive technology, more women of this cardiac disease are planning for their pregnancies. This is a domain where this not only one man can do its obstetrician. It's just a joint venture from this anesthesiologist, obstetrician, and the cardiologist. They have to work together, jointly analyze and discuss the cardiac problem. Even patient is not going for this cesarean section, but the plan is always there. The patient might go for surgery. If we even go for this vaginal delivery, also the involvement of the anesthesiologist from this prior in the planning is better, and make the rational choice of their management. Anesthesiologists, the skill and experience on the common potential is intraoperative problem is essential, and it's with every anesthetist. But ability to respond this quickly hemodynamic disturbance is more important than choosing the specific technique or any agent. So concluding with this is, despite the potential difficulties, complication associated with the congenital heart disease, careful cardiac, obstetric, and perioperative anesthetic management in a tertiary referral center resulted in a good maternal and the fetal outcome. Thank you.